Thank you very much, Chairman. Ladies and gentlemen, I'll go through this management protocol for ventricular septal defects, accepting that there will be not only pediatric cardiologists, cardiac surgeons, but general pediatricians in the audience, and hopefully we'll cover some of these areas. Now, ventricular septal defects are classified in according to different locations. For example, defects in juxta-arterial or subarterial position are called doubly committed subarterial or supracrystal or infundibular VSDs. Different terminologies are used. Perimembranous VSDs are in that sort of region, usually subaortic. Inlet VSDs around the tricuspid mitral valve apparatus are in that position, and then more towards mid-muscular and apical are called muscular VSDs. Now, ventricular septal defects are probably the commonest heart defect. In the literature, you'll find that the incidence is about 25 to 30%. UK data a few years ago showed that the incidence of ventricular septal defects was 32%. So it was the commonest heart defect lesion encountered in clinical practice. The significance of VSDs is really based on that, not just the history and physical examination, the routine sort of investigations such as ECGs and chest x-rays, but echocardiography is the mainstay, and there's not much doubt of this sort of inlet VSD where I'm talking about a defect where there is a deficiency of the septum in the inlet portion, and this is a very large ventricular septal defect. Now, in the newborn period, immediately after birth, we know that the pulmonary vascular resistance is high. And that high PVR or pulmonary vascular resistance has a limiting effect on the pulmonary blood flow and therefore keeps the left to right shunt at a reduced level. The natural history or progression of pulmonary vascular resistance is that of a fall over a period of 4 to 6 weeks. It falls gradually, and as the pulmonary vascular resistance falls, there's an increase in pulmonary blood flow due to increase in left to right shunt. The large VSDs may be associated with a delayed fall in pulmonary vascular resistance. So, although you might expect them to develop heart failure and symptoms within the first week or so, symptoms are often delayed for anywhere up to 4 to 6 weeks. And that fall in pulmonary vascular resistance has that sort of controlling effect on the development of symptoms. When the pulmonary vascular resistance is at its lowest, the flow through the VSD is at its highest, and that large left to right flow, unrestricted blood flow, results in heart failure appearing in about 4 to 6 weeks of age in a baby. And that maximum hemodynamic effect in large VSDs may not be reached for several weeks, and it really is the pulmonary vascular resistance which determines the timing at which symptoms and signs may appear. In babies with high pulmonary vascular resistance, the rate of fall of the pulmonary vascular resistance is multifactorial. The rate at which the pulmonary vascular resistance has fallen and then starts to rise again is variable. It can be many months to several years. And it's really when the pulmonary vascular resistance starts to increase, let's say 5 years or 10 years later, that the flow through the VSD starts to decrease. And that's because the pulmonary arteries have been exposed to a high pressure and flow for a prolonged period. And that problem then becomes an issue beyond 12 to 18 months of age or later. A high pulmonary vascular resistance due to pulmonary vascular disease, as it develops from that high pulmonary blood flow, it reduces the left to right shunt, and so what happens is, perversely, symptoms of heart failure start to improve, and babies and children actually improve. And that doesn't necessarily mean it's a good sign. It's a false reassurance for families as well as clinicians. And eventually the pulmonary vascular resistance is so high that the flow across the VSD becomes right to left, and cyanosis develops, and that's what we call Eisenmenger syndrome. So it's very important with VSDs to make an accurate diagnosis, to define the size of the VSDs, or either single or multiple, evaluate their effects and hemodynamics of the VSD, look at cardiomegaly on the chest X-ray. ECG evidence of left ventricular volume overload and right ventricular hypertrophy may be present, and echocardiography is the absolutely crucial mainstay investigations in the evaluation of ventricular septal defect, because we want to assess the impact of the defect on the patient. Echocardiography is the mainstay, as I mentioned, but nowadays, instead of proceeding with cardiac catheterization, we evaluate them by MRI as well, but these are all reserved for difficult decisions. Usually, those babies who need treatment for heart failure from a VSD alone, surgery can be recommended or catheter closure can be recommended purely based on echocardiography and the symptoms and signs alone. In developing countries, about 10% of babies with large VSDs, unrestricted VSDs, untreated, die in the first year of life. And that's largely because of severe congestive heart failure and infections occurring. Spontaneous closure is really uncommon in large VSDs, but those that VSDs that are moderate or small, or what we call restrictive, about 30 to 40% may close spontaneously, and the majority of them, if they're going to close, the closure occurs up to 10 years of age. And a reduction in the size of the VSD may occur in a further 25%. So up to 65 or 70% of patients of large VSDs, moderate-sized VSDs, may reduce in size and actually not cause symptoms or problems. Going back to 1993, Langford Kidd reported on over 1,200 patients who had surgical or medical management of VSDs, and the data was reviewed. The 25-year survival in that population was 82%, and about a quarter of the patients who were managed medically needed surgical closure. About 3/4 avoided it. And those 5.5% of patients who had surgery needed a further operation because of a residual shunt or residual defect. Interestingly, endocarditis was reported in around 15 per 10,000 years of follow-up in these patients with ventricular septal defects. There was another paper back in 1998 from Krovets, over 1,000 patients. 160 of them were lost to follow-up. There were about 750 patients who were followed up for more than 3 years, and there were 18 children who died, and there were only 2 of them were due to congestive cardiac failure. The others died for other reasons, such as infection. And out of that large population of 1,000 patients, only 39 patients needed surgery. And spontaneous closure occurred in 71% of the patients. And you can see the rate of closure on this curve. And the majority of them, if they're going to close by about 10 years. There's a very smaller, further increase, smaller incidence of spontaneous closure beyond 10 years of age. But the majority close by 10 years. So when faced with babies and children with VSDs, our decision to treat them is based on not just symptoms, but echocardiography, as I keep mentioning, is the mainstay. And cardiac catheterization really is very rarely performed, and only if pulmonary vascular resistance becomes an issue. What are the complications related to VSDs? Babies can develop congestive heart failure, there can be delay in growth, recurrent chest infections are a big problem, onset of pulmonary hypertension is a potential complication. They have large left to right shunts, the Doppler velocity usually is less than 3 meters per second, and the VSD size, what we call large, is larger than half of the aortic root size. So we've got something to compare the size of the VSD with, and that is the aortic root or aortic valve at the leaflet attachment points. This is an echocardiogram of a large VSD. In this case, there is malalignment, and the aorta is slightly overriding the septum. In these large unrestricted VSDs, usually they have symptoms of failure to thrive and congestive heart failure. The chest X-ray may show cardiomegaly and pulmonary plethora, and echocardiography in large VSDs, the VSD itself is equal to the diameter of the aortic valve. That's one of the reasonably objective definitions of large VSD. The right ventricular pressure is systemic, it's equal to the left ventricular pressure, and like I said at the beginning, the degree of left to right shunting really will depend on how slowly or how rapidly the pulmonary vascular resistance falls. The symptoms of congestive cardiac failure consist of easily getting tired, poor feeding, breathlessness during feeds, and sweating, especially around the forehead during feeds. And the signs include failure to thrive, tachypnea, increased respiratory effort, tachycardia, sweating being present, pallor, hepatomegaly, and gallop rhythm. We treat congestive cardiac failure in the first few weeks of life by supplementing with calorie intake. Nasogastric tubing may be instituted if growth is slow and the oral intake is inadequate. Diuretics in the form of furosemide, 1 milligram per kilogram, either once a day, twice a day, or 3 times a day may be appropriate, in combination with spironolactone, 1 milligram per kilogram, once, twice, or 3 times a day. Instead of the spironolactone, we can give captopril to reduce the systemic vascular resistance, and maximum dose of that is 1 milligram per kilogram 3 times a day. And a combination of furosemide and captopril may buy us a few weeks, if not a few months, to allow the babies to grow sufficiently to undergo surgical treatment of ventricular septal defects. Here's some pictures of a large subaortic ventricular septal defect with some malalignment, with a little bit of override, and you can see a very nice paramsternal long axis view. And here there is left to right shunting through this large VSD, but in particular the Doppler velocity is less than 2 meters per second. A short axis view shows the large ventricular septal defect again in that projection. And there's the left to right shunt through this large VSD. Subcostal view can give us additional information about any possibility of restriction of the left to right shunting through the pulmonary valve. And here's the blood flow left to right shunt through the VSD and through the pulmonary circulation. This is a still picture of a large muscular VSD, and these can cause problems. Perimembranous VSDs are the commonest defects really that we have to deal with in that first year of life. So how do we treat these? Well, we treat them with diuretics and ACE inhibitors, as I mentioned. Medical treatment may be appropriate for up to 3 months in such large VSDs, and if by then there is no response to treatment or inadequate response, then we recommend surgery. And usually surgery is delayed up to about 3 months of age, but occasionally if the baby is struggling, then we operate at less than 3 months if the symptoms are a major problem. And nowadays, the mortality from VSD surgery should be around 1% and certainly less than 2% in the best centers. So, as I mentioned, large VSDs with uncontrolled congestive cardiac failure usually need surgery in the early infancy. Large VSDs with pulmonary hypertension, it's best to delay surgery up to about 3 months for the fall in pulmonary vascular resistance to optimize. And this is a flow chart of how to manage large VSDs in infancy. So a trial of medical treatment is appropriate, and if there is improvement, then you can reassess at about 3 months and recommend surgery after that. If there is no improvement in less than 3 months, then usually we would proceed with surgery within that first 3-month period. Moderate or slightly restrictive ventricular septal defects, these are defects that may not cause heart failure or failure to thrive, or if they do cause those symptoms, then they may improve with anti-failure treatment. Chest X-ray usually shows some cardiomegaly and pulmonary plethora. Echocardiography in moderate-sized VSDs usually shows that the defects are between half and 2/3 of the aortic root or aortic valve. The right ventricular pressure based on Doppler velocities may be half to 2/3 of systemic, so the velocity is around 3 to 3.5 meters per second. And left to right shunt, if you calculate that, is usually more than 2 to 1. The pulmonary artery pressure, because of the moderate restriction, will be half to 2/3 of systemic. And these defects, we tend to close them if they're continuing to cause problems in the first 1 or 2 years of life, and only treat them earlier if there is life-threatening lower respiratory tract infections on a recurrence basis, or if there is persistent failure to thrive. So it's worth trial of medical treatment with these moderately large diuretics, similar to large VSDs with diuretics ACE inhibitors. You can give the medical treatment for a longer period, up to 6 to 12 months, and if then there's no response, you can either refer them for surgery, or if the defects are in an appropriate location, device closure may be adequate. And at beyond 6 to 12 months of age, surgery should carry a mortality risk of less than 1%. So here's a flow chart for moderate VSDs. Medical treatment for heart failure, if that's present. If there is improvement, then we carry on treating them conservatively without surgery or device closure. If there is no improvement over 6 to 12 months and the shunt is large, then surgery at about 12 to 18 months, or device closure if that is defect is in an appropriate position. The small to restricted VSDs usually have no symptoms whatsoever. Chest X-ray may actually be normal. Echocardiography will show the defect of less than 1/3 the size of the aortic root. The right ventricular and pulmonary artery pressures are normal. Left to right shunt is less than 2 to 1, and the Doppler velocity is more than 4 meters per second. And here's a small restrictive perimembranous VSD with a small left to right shunt. You can see restriction on this with a high velocity jet, which in this case reaches almost 5 meters per second. And so that is a restrictive VSD. This is a small apical VSD with a very small left to right shunt and Doppler velocity of more than 3.5 meters per second. And these are small defects where you would not really recommend surgery or device closure in these patients. There are multiple VSDs, as in this case here. There are several defects. The net effect may be actually adding to a large left to right shunt, and these may need to be treated. And it depends on the number and the size of these. Here's some color Doppler flow through these multiple VSDs. Here's some costal view showing left to right shunts, view of the ventricular septum, and here's some color Doppler flow from the apical four-chamber view. And these are small defects which may actually not cause any problems, but if there is a large net left to right shunt, then these defects may need treatment. So, like I said, insignificant or significant VSDs, it's very easy to sort out a pathway of treatment. But if there are small VSDs and they're complicated by the onset of aortic regurgitation, then the treatment pathway may have to be changed. So here's a very small restrictive VSD in a baby or a patient who's developed aortic regurgitation, as you can see, and here's a different view of the VSD as well as aortic regurgitation. And here you would then have a different threshold for recommending surgical treatment. Here's another defect with a prolapse of the right coronary cusp and onset of mild aortic regurgitation. Here's another patient with a VSD that's almost closed, but there is onset of moderate aortic regurgitation from a prolapse of the right coronary cusp, and some 3D pictures of a prolapsing right coronary cusp. And in these patients, therefore, you may have to recommend surgery even though the net left to right shunt is small. In adults, that can be a problem in that they present with the presence of a small VSD. Small VSDs only need an operation in adults if there is a prolapse of the right coronary cusp or onset of aortic regurgitation, or if they've had an episode of endocarditis. But in adults, if there is a large VSD, then they're likely to develop established pulmonary vascular disease, and therefore surgery should be avoided or is contraindicated. There's a study back in 1998 by Neumeier of 188 adult patients from 17 to 72 years of age. Even in adult life, the spontaneous closure occurred in a small percentage of 10% of patients. Endocarditis was a big issue, 11%. Aortic regurgitation developed in about 20%, and atrial arrhythmias in about 5.5%. So, a course of an adult VSD is not necessarily benign based on that sort of study. So, the treatment depends on various factors such as age, presence of uncontrolled congestive cardiac failure, 3 to 12 months if there is congestive cardiac failure or uncontrolled pulmonary hypertension, more than 12 months if there is a net left to right shunt of more than 1.8 to 1. But there are some contraindications. If you do catheter studies and the pulmonary vascular resistance is more than 10 units, or QPQS is less than 1.5 to 1, then those are patients who should not really undergo ventricular septal defects. The defects that cause probably the biggest problem, I think, in terms of management decision are the small restrictive VSDs, such as small VSDs that are less than 3 millimeters without aortic valve prolapse. And these are patients that we would just carry on reviewing in the clinic every 2 to 5 years, looking for development of aortic valve prolapse and aortic regurgitation. Another group is small outlet VSDs with aortic valve prolapse, and you can see the leaflet prolapse, but there's no aortic regurgitation. And here there is controversy in their management, because either you go straight for surgery and prevent the onset of aortic regurgitation, and some units recommend that. Others manage these conservatively until aortic regurgitation develops, and then surgery is recommended. There will be some perimembranous VSDs with any degree of aortic regurgitation, where you'd actually recommend surgery whenever aortic regurgitation develops. There are some perimembranous VSDs with aortic prolapse and no or mild aortic regurgitation. Again, you would keep those under review in the clinic until any evidence of aortic regurgitation is noted. So what are the problems if treatment is delayed? Well, in small VSDs, it's not a problem. There is no possibility of developing pulmonary vascular disease and Eisenmenger's. Endocarditis is the only risk, and even then that is very low. Of course, I don't know about Pakistan or South Asia. In Europe, it's very low. Need to diagnose the VSDs in case there is subsequent development of prolapse of the right coronary cusp leading to aortic regurgitation. And therefore, it's best to manage these by investigating them with echocardiography on a regular basis. In large VSDs, the consequences of misdiagnosis or delayed referral are enormous. Because the baby may be committed to prolonged failure to thrive and recurrent chest infections. Prolonged medical treatment may be given for congestive cardiac failure without an accurate diagnosis. The most severe consequence, however, is the development of pulmonary vascular disease. And therefore, in the modern era, no baby should be allowed to develop pulmonary vascular disease without confirming with echocardiogram in early infancy and managing them appropriately. Because the consequence of pulmonary vascular disease on the patient, the family, the social circumstances are severe, and these have a permanent restriction effect on effort, and unemployment, increasing cyanosis, long-term oxygen treatment, and ultimately, certainly in developed countries, the need for heart and lung transplantation. So, in the West, for sure, treating such a baby with large VSD without a confirmatory echocardiogram almost amounts to clinical negligence, and that would be a huge problem for the clinicians. There are other implications for pulmonary vascular disease in large VSDs, and those are cost implications for management, long-term oxygen costs, long-term treatment with oral prostacyclin or bosentan, and long-term treatment if these babies do reach heart-lung transplantation, long-term treatment with immunosuppression. So prognosis of pulmonary vascular disease is poor, although survival into adult life is common. Death usually occurs before 40 years of age, but in females especially, pregnancy can pose a huge risk and therefore should be avoided, because maternal mortality with Eisenmenger syndrome may be anywhere up to 50%, and so that needs to be managed very carefully. So just to summarize, VSDs that cause problems in the first few months of life, large unrestricted VSDs, should be treated by surgery in infancy. Catheter closure for a VSD with a device is reserved for moderately restrictive or restrictive VSDs, for example, muscular VSDs in babies weighing more than 8 to 10 kilograms. If they are a problem in less than 8 to 10 kilograms, then hybrid procedure may be required. In those defects that are in a difficult location, such as at the apex, hybrid closure may be required. In those with multiple VSDs, pulmonary artery banding may still have a role to play, and especially those with multiple VSDs, babies weighing less than 2 kilograms, might need to institute staged treatment. I'll stop there in the interest of time. Thank you very much for your attention.